You have been given a case of a young woman presented with painful, stiff fingers. Regarding differential diagnosis, make a quick list of possible causes of a given presenting complaint, and ask questions to rule in, or rule out, the possible differentials, as in this case. Rheumatoid arthritis, ankylosing spondylitis, gout, are the top differentials in our list. Here, we are discussing relevant questions to take a brief history, keeping ourselves structured within a given time frame. Ask about pain questions using SOCRATES PDA site. Where exactly do you feel the pain most? Moreover, check, is the distribution of symptoms as monoarticular or polyarticular? The involvement of joints is in a symmetrical or asymmetrical pattern. Either large or small joints are mostly involved. Any signs of involvement of ligament or tendon insertions? Onset, how did the pain start? What were you doing when it started? Is it the first time or there were previous episodes? Determine, is it sudden or gradual in onset? How have the joint pains been affecting you? Character, can you please describe the pain for me? Next, ask about radiation. Does this pain go anywhere else? If the answer is yes, then ask where it goes. Associated symptom. Ask for any morning stiffness, joint pains, swelling, and deformity. Any restrictions in the range of movement of the spine, or any painful eyes, blurring vision, and ask, does the light hurt you? Let's ask about the details of these association. Firstly, check for the presence of joint pain in timing. Are they most painful first thing in the morning or later in the day? Pain due to inflammatory arthritis causes worsens in the mornings, whereas pain due to degenerative conditions progresses throughout the day. Swelling. Do your joints swell? The presence of synovial swelling differentiates arthritis from arthralgia. Stiffness. Do you feel your joints become stiff when you wake up in the mornings? How long does it take you to get them to be normal? Joint stiffness helps to differentiate inflammatory arthritis from degenerative conditions, as morning stiffness greater than 1 hour is typical associated with rheumatoid arthritis. 4. Rash. Ask about, where is the skin lesion? When did you first notice the skin lesion? How does the skin lesion feel when you touch it? How many skin lesions are there? What shape are the skin lesions? Next, ask about orogenital ulceration. Oral ulceration is associated with systemic lupus erythematosus, Behçet's disease, and reactive arthritis. Furthermore, eye symptoms. A red or painful eye may be a consequence of episcleritis or scleritis in rheumatoid arthritis. And dry, gritty eyes suggest keratoconjunctivitis caused by Sjogren's syndrome. Exacerbating factors. Does anything make it worse? Further, ask about relieving factors. Does anything make it better? Ask, have you tried any analgesics? Scale. If I was to give you a scale from 1 to 10, 1 is lowest and 10 is highest, how do you scale the pain? You may ask, does the pain keep you awake at night? Night pain suggests malignancy or very severe arthritis. Progression. Has the pain changed over time? Is it the same, getting better, or worse? How is this pain different from previous episodes? Duration. How long it is present, as the pain lasting less than 6 weeks may be due to viral infection, whereas after 6 weeks rheumatoid arthritis is a more likely cause. Anything else? At this point, we have ruled out possible differentials and make our approach aligned towards a definitive diagnosis. To support it, we can perform a quick physical examination and lab investigations. As in this case, we can check hands for symmetrical and deforming polyarthropathy, volar subluxation and ulnar deviation at the metacarpal joints, subluxation at the wrist, Swannick deformity, Boutonniere's deformity, Z-thumbs, muscle wasting, surgical scars, bicarpal tunnel release, joint replacement, and tendon transfer. Rheumatoid nodules on elbows. To assess disease activity, look for red, swollen, hot, painful hands that imply active disease. Next, to check function of joints, perform power grip, as to squeeze my fingers. Precision grip, by picking up a coin or do up your buttons. Key grip, by using this key. Remember the wheelchair, walking aids and splints. Moreover, look for any treatment effects, like steroids-induced Cushingoid burns and cervical spine stabilization scars. Meanwhile, assess for systemic manifestations of rheumatoid arthritis, including pleural effusions, fibrosing alveolitis, obliterative bronchiolitis, Kaplan's nodules, scleritis, carpal tunnel syndrome, atlantoaxial subluxation, quadriplegia, peripheral neuropathy, Felty's syndrome, pericarditis, nephrotic syndrome. Now it's the time to tell the patient about the management part, including investigations and treatment. Regarding investigations, we have options of elevated inflammatory markers, radiological changes, including soft tissue swelling, loss of joint space, articular erosions, periarticular osteoporosis, and positive rheumatoid factor. Regarding treatment, for symptomatic relief, NSAIDs and COX-2 inhibitors are top among available options, and early introduction of disease-modifying anti-rheumatoid drugs to suppress disease activity. Furthermore, ongoing disease activity may require immunomodulation therapy, including infliximab, etanercept, and adalimumab. Meanwhile, supportive therapy comprises of explanation and education, exercise and physiotherapy, occupational therapy and social support. Next, option for treatment is surgery, including joint replacement, tendon transfer, etc. Meanwhile, address the concerns of the patient. In the end, it's the time to close the case and talk to the examiner.